Well, here we are at what I'd call the central mystery of prevention. The picture with this rather childish big arrows is meant to be bold and straightforward. The first thing you want to know is what the stones are made of, because the thing you want to do is stop these crystals from continuing. The stones get analyzed, and there's a group of decisions here. If they're uric acid, there's nothing you can do but make the urine more alkaline. These stones can be cured, they can be dissolved, and so knowing if it's uric acid is critical. You can know if the stone is analyzed. If there's a CT, your physician can get the radiographic density of the stone, so-called Hounsfield units. Values of 300 or 400 make very high likelihood it's uric acid. Values for calcium stones tend to be near 1,000. Here and there and rarely, stones are cystine. That's a disease of its own. It's hereditary. For uric acid, we have a great link for you. If you go on that link, it tells you everything you could imagine. For cystine and stones, we have another great link. Sometimes stones are made of struvite, magnesium ammonium phosphate. They're caused by bacteria themselves. The metabolic profiling and everything else that this site specializes in is not the main point. These are infected foreign bodies, and they're a matter for medical surgical management, and they're outside the scope of this site currently. Most of the time, the stones will be calcium stones. That's the one that we mostly need this complex apparatus in order to treat. This diagram makes things look clearer and simpler than they are. This calcium stone diagnosis can sometimes be very indirect. It comes from the fact that the Hounsfield number of the stone is too high for calcium stone. It can come from the fact that the kidney stone testing has already been done and screening for cystine is negative. It can come from the fact that the stones don't look like struvite on a CT. The best is when the stones are analyzed. All the rest is a bit indirect. So if you have stones, or if you have had stones removed, move heaven and earth to get a diagnosis from stone analysis. Ultimately, most people come down to calcium stones, and they arise basically from 5 big categories: bowel disease, primary disorders of overproduction of oxalate, kidney tubule disorders that are rare, and primary hyperparathyroidism. The rest are called idiopathic, and that's how the thing breaks down. These conditions, primary hyperparathyroidism and tubule disorders, they're diagnosed from serum and urine testing, and it's done by your doctors. I can't teach you how to do this, but I can teach you to expect your doctors will have done it. That's their job. Most people know if they have bowel disease. Here and there, uncommonly, silent malabsorption can occur and raise urine oxalate. That's not very common. Very high levels of urine oxalate, 70, 80 milligram a day, are the usual clue to primary hyperoxaluria. This is what your doctor does. she or he figures out if you have that. Most of the time, none of these issues are raised, and you have so-called idiopathic or common calcium stones. That's what this site is mostly about. Even though it is the responsibility of your doctors, I don't want any patient to feel paralyzed when it comes to recognizing these tubule disorders and primary hyperparathyroidism. I have created these links to articles that give a lot of material for patients. If there's any suspicion of them, read up and be sure you're getting the care you need. The hyperoxaluria from bowel disease is also on the site. And I've got a lot here for oxalate excretion. In other words, you can be very, very well educated about the underlying problems. All of the information comes from the 24-hour urine and serum taken together. In the event you have the common calcium stone, the main causes are fairly straightforward, and here they are. A high urine calcium, above 200 milligram a day. You've seen that already, that's the first video. High urine oxalate, above 25 milligram per day. You've seen that in the video. A low citrate, below 400 milligram a day. You saw that in the video. A urine volume that's under 2 liters a day, and you saw that. The high urine calcium arises because of genetic idiopathic hypercalciuria, and this link takes you to a very detailed analysis of that condition. And it's treated particularly with reduced diet sodium. If you keep your protein in the normal range and avoid refined sugar, it also helps, because very high diet protein and excessive use of refined sugar raise urine calcium. This is the condition where thiazide diuretic agents are used. Likewise, you need diet calcium to prevent bone disease. And this is covered in these links. When urine oxalate is above your critical point, it can be treated with adequate diet calcium because that reduces oxalate absorption. And these links take you to an analysis of that. And likewise, you want to reduce your oxalate intake to a reasonable level by using lists of high oxalate foods. And I've made a note here of the worst foods. Citrate is an inhibitor of crystallization, and it's calcium binding. And here is excellent material on citrate. You can take potassium citrate. If you're eating adequate amounts of fruits and vegetables, you're going to get quite a lot of potassium in the form of potassium alkali, even from diet. As for urine volume, I hardly need to teach that to you. This little diagram is packed full of knowledge. It gives you actual numbers. Get your diet sodium under 2,000 milligram a day. Keep your diet protein under 1.1 gram per kilo per day. This number comes right off your 24-hour kidney stone report. Get your diet calcium to the U.S. recommended, 800 to 1,000 milligram minimum. Get your refined sugars below 25 gram per day. Get 5 servings of fruits and veggies. Rather a lot of information for a small picture like this, isn't it? The so-called kidney stone diet is just a name that we made up to contain all of the things you just heard. The 5 diet elements correspond to what I just said, which is that you want reduced diet sodium, that's to block calcium loss. You want reduced sugar and protein to block calcium loss. And this allows you an adequate diet calcium without raising the urine calcium. So you have calcium for your bones, and that calcium will block oxalate absorption. You want fruits and veggies to give you your diet potassium alkali. This is a nice word, and the diet, so-called kidney stone diet, corresponds perfectly with the healthy diet recommendations for everyone in America. Because that's true, the kidney stone diet isn't for people with kidney stones. It's actually the ideal diet for their doctors and their family members and their friends. So basically, everyone should be eating this way. You might say, well, what about the need for drugs? I've been vague. Well, how you strategize diet treatment with drug treatment is in the review that I've got my cursor on. That's a terrific article, and I would strongly urge that you read it because it actually integrates testing, the use of diet, and the use of drugs, and how one puts it all together. This is an introductory chapter. It's not meant to finish the story. The diet is also important because more is wrong with stone formers than just stones. There's links between stone formation, I'm reading this to you, and risk of high blood pressure, bone disease, stroke, heart attack, and kidney disease. The links to the evidence for this. I don't know why there are these links. Neither does anybody else. I suspect that there are genetic reasons that link having these diseases to having stones. What this boils down to is that when you form stones, you should be getting treatments that act to bring improved health across the board. That's why this little phrase here, treat the patient, not the stones, and this link takes you to a whole article on that subject. I can't impress on you how important it is, because what's coming up next is my favorite dislike. The idea, the insane, stupid idea of turning a stone former away with drink more. I resent it, and I consider it a very poor quality of practice. I'll come back to that in just a second, but before I close out and enter into tirade, stone disease is part of a general pattern of disease. The ideal diet for kidney stones is the ideal diet for everybody. Do it. Okay, let's talk about water alone as a treatment for stones. First of all, the good news. It has been tried and it will work. Here is a story. People with a single kidney stone, known to be an idiopathic calcium stone former, okay? So these are people who ruled out for systemic disease, have formed calcium oxalate stones, and only one stone each, single stone formers. Two groups. One group was driven to 2.6 liters a day on average over 5 years. The other group about 1 liter. Now you already know from what I taught you, 1 liter is super high risk. Even getting from 1 liter to 1.7 liter would have dropped the risk more or less the baseline. They went up a whole liter more. This is a huge urine volume. Of course, the supersaturation from 9 to 2 for calcium oxalate, from 1.5, which is too high, to under 1 with CAP. So the good news is water will work. And here's the outcome. At the end of 5 years, 12 people, that's 12%, of group 1 had made a new stone. 27 people made a new stone in group 2. Now, I suspect 1.7, 1.8 liters would have given you close to this with a lot less trouble. So I don't think that for single stone formers, water won't work. I suspect it will work. It's just a poor treatment. Here's why it's a poor treatment. Because people with stones can have genetic hypercalciuria with a high risk of bone disease. They should have calcium extra for their bones and low sodium to keep the calcium in their bones. If they have low citrate, their diet should be changed so as to improve it. If they have high urine oxalate, the higher calcium intake will take care of that. Naturally, you should get your urine volume up to around 2 liters. Furthermore, if they're eating too much refined sugar, it's bad for their health and for the urine calcium. And if they're eating too much protein, it's bad for the urine calcium. And finally, they should be eating their fruits and veggies to give them potassium. It's good for hypertension, and it gives them more citrate. These measures, these diet measures, are towards a healthy diet. Giving just water may prevent that first stone or reduce it, but it's not giving them better health. Stone formers have more wrong with them than just stones. Second, there's 12% relapse. So that's in 5 years. That's 2.4% per year. So at 2.4% per year, that's 24% per decade. What's good about that? By the end of a couple of decades, you have a tremendous relapse rate. So water alone is not a good treatment medically, and water alone isn't even that good at stone prevention. It's just okay. And certainly the people are not being taught about nor turned into a good diet, and they have lots wrong with them. So it's very mediocre. Also note, this was very unusual conditions. There were nurses supervising. The cost of supervision was underwritten. Just to rely on a single modality in the outside world is going to give you a pretty high likelihood that people will lapse, and some will drop below the 1.8 or 2 liter threshold. It's probably not reliable even. There's another aspect to it. If you have a single stone, you have a fairly low risk of a relapse with treatment. 10, 15% maybe. This is 10%, 20%, 30%. If you have more stones before you begin treatment, average of 2 stones, average of 3 stones, average of 4 stones, your likelihood of relapse, even on the drug arm of the randomized trials, that's what's plotted here, keeps going up with the number of stones you've made. So if you take single stone formers and rely on a single modality, and they go from 1 to 2 stones, their risk of a lesser outcome is going up. It goes up progressively with more stones. So not only is it poor medical advice and mediocre, and maybe not even reliable without nursing supervision, but as you make more and more stones, you become more and more likely to make stones, even if you are in the active arm of a treatment trial. These are all drug treatments. Even there, more stones mean a higher risk. So for every imaginable reason, you don't just want to put people on water alone. You want to improve their diet and, of course, maintain hydration, and then use drugs as needed. This little graph was peeking up at you just a second ago, and I want to show it to you in detail. This line here shows time over which people were observed before their doctor sent them to me for stone prevention. people sent right away. The average person was sent at about 2.5 years after their first stone, something like that. As the time to referral went up and up, essentially the time left untreated, up to 15 years, the number of new stones kept going up. In other words, if you just allow people who have made one stone to keep going, they will make more and more stones on average. The event rate, stones per patient year, stays pretty constant. What this says is a very subtle but important point. If you're a single stone former, please don't agree with your doctor when he or she says, hey, you've only had one stone, drink a little water, drink a lot of water, forget about it, probably won't happen again. It probably will happen again. Or at least our data say that if you end up in a group of people referred for stone treatment, it will have happened again. A single stone means you're a stone former. And that's that. As far as I'm concerned, every stone former should be evaluated exactly the same way. Another reason that every stone former should be evaluated the same way, who knows which stone former harbors a systemic disease, hyperpara, a tubule disorder, high urine oxalate, some rare ones, very high urine oxalate. You can't afford not to look. Don't accept waiting just because you've made a single stone. Just like don't accept water as a monotherapy. Well, we're coming to the end of the chapter, and presumably we are on treatment. Things are going well. What do you do then? Well, you maintain your treatment. This is odd but important. Always analyze every stone. I know you've made calcium oxalate stones 5 times. Infection can occur, and struvite can show up. You won't really know. Sometimes the X-ray appearance gives you the answer. Why guess? As you get older, gain weight, get diabetic, the urine can become acidic, and uric acid can form. Uric acid stones require highly specific treatment. I told you that at the beginning of this article. And it's a different treatment from all other stones. So, if you analyze a stone and you catch the uric acid, you can abolish it. We have observed and published that calcium oxalate stones can turn into calcium phosphate stones. That could be bad. The calcium phosphate stones can grow faster, and they tend to invade the tissue with crystals. So you want to know that. It would raise your treatment energies. Also, potassium alkali may be very good for calcium oxalate stones. They may not do well for calcium phosphate stones. Never been a trial. So you need to know about changing stones. Stone analyses are not the greatest thing. I quoted here a link for a really great paper on the failures of stone analysis. My own work with Joan Parks, on the other hand, suggests that overall they're pretty serviceable. Make your own decisions about quality, read the papers, but as far as I'm concerned, get your stones analyzed. Don't let your doctors throw them out. Always analyze them, just in case. As for follow-up 24-hour serum measurements, how can you possibly do anything without knowing if it worked? For diet change, 6 to 12 weeks. For drugs, the same. I think it's very important. When you're stable and there's no new stones, I would check in once a year just to be sure. I have some wonderful articles. I say wonderful because I wrote them. How to prepare for your testing, how to get the most out of a physician visit. And there's more background in this book. So at this point, I should sum it up and say something wise, and I'm not so sure I'm up to it. Basically, there's a lot of ways to make stones. For treatment synergy, you want to know all the things that are wrong, and that means proper testing. Stone analysis is more than crucial. It's the center of everything. And then prevention is precise. Look to see what's wrong with you, get it fixed. Ideally, it's multivalent. You'll do everything you can with diet to fix whatever is wrong in the urine. And if that doesn't do it, you add medication to the diet. Never accept the idea that just because you've had one stone only, you should let it go. Never accept the idea that water alone is just great, because it isn't. I hope you've enjoyed the 2 videos. I hope you enjoyed this chapter, and I hope it does you a lot of good. Thanks for listening, and bye-bye.